Well, thank you so much, everyone, for joining us today. This is our behavioral medicine didactic series, and we are so pleased to be joined by Sarah Carstens, our addictions clinical director at Penn Medicine, Princeton House Behavioral Health. She's here today to give us a big picture overview of substance use disorders, sort of like the 101 level class in parallel with our eating disorder lecture last week. And then our upcoming combination of eating disorder and substance use disorder treatment approaches. For those of you that are interested in CEU credits, we do have CEUs available for the EEGS system. That code is 86 SHED, SHED. So 86 SHED. And I'll let folks know again at the end of the meeting as well. So thank you all so much for joining. I will be monitoring the chat for questions during the talk, and we'll help with our discussion at the end. But please try and keep your cameras off and yourselves muted for the conversation initially. And I will let Sarah take it away. Thank you so much for joining us.
Thank you, Dr. Boswell. Thanks for having me. So I'm going to go ahead and get started in just a minute. I just wanted to share a couple of things really quickly before I launch in. So as Dr. Boswell shared, and as you can see by the title of this first slide, this is Substance Use Disorders 101. So this is a very, very foundational training, if you will, on substance use disorders. So for those who may have been, working in the field for a while, have had a lot of experience with substance use disorders, I hope that you will find some information in here that's maybe new or that you just hadn't considered before, but it will be very, very basic. We're going to look at, some of the trends of use. We're going to look at how we view substance use along with how we diagnose it. And we're going to really spend a considerable amount of time today looking at the different drug classes. One of the things that I have found is that people are often really uncomfortable treating things that they don't know a whole lot about. So if you don't know the difference between Vyvanse, Valium, and Vicodin, it can be easy to understand why substance use disorders, may be a little bit daunting for you. This is going to be a really, really broad overview. And at the end, we'll also look at some really important treatment and clinical considerations. Next week, I'll talk a little bit more about like specific modes of treatment and things like that. But for today, it's just going to be some considerations. My second quasi-announcement is that in approximately 20 to 25 minutes, my children are going to be coming home from school. So if it sounds like chaos has erupted in my house, that's because it has. And I just ask that you please try and ignore it, as I will be doing. All right, I have a very, very ambitious agenda for today, so we're going to go ahead and just launch right in. Here we go. So why are we even talking about this? It is really hard not to talk about this topic. When we have seen both historically and currently the impact that substance use has had on our country, on our communities, our friends and family, it is definitely an area that is deserving and needing some focus and attention, especially for those of us who are working in the behavioral health field. It is all around us and it breaks through all barriers, gender, race, socioeconomic status, and beyond. Addiction, substance use knows no limits, unfortunately. Additionally, people with substance use disorders typically experience so much discrimination, are often multiply marginalized, receiving less than adequate care. So to, kind of build up the next generation of individuals who are working in the field of addictions is incredibly important to be able to give this population the care and treatment that they deserve. I do want to acknowledge and recognize that it can be really scary working with this population. There is definitely risk involved, and it can feel challenging and taxing at times. And the reward is so great. This is obviously I'm a bit biased, but this is definitely one of my favorite populations, my favorite population to work with. And I hope that being able to bring some of this foundational knowledge for those of you who may not be as familiar will calm your nerves a little bit and allow you to see things a little bit differently, and hopefully be able to expand your comfort in working with this population. So let's take kind of a historical look and a historical perspective on substance use. As you can see, this graph is coming from the Monitoring the Future study out of the University of Michigan, one of the biggest, tons and tons of data, lots of data points, and they continue to add data points. As you can see, the number of lines expands as they've gone through the years. What this graph is showing is any past use in the last 12 months, and it is broken down by age group. So starting at 18 years is the top, the blue line with the solid blue, so this one right here, and then it goes on down, and they just recently, within like the past 5 or 6 years, added a 60 years plus category, which is what you can see on the bottom right, the solid blue line with the white blue circle. And what you can see here is that we had substance use, I guess, kind of peaking late 70s, early 80s, and then there was a fairly steady decline up until the early 90s. We saw a slight surge, but overall, what you can see is that the use patterns have varied a bit over time by age group, but generally, since really like the mid to late 90s, there haven't been any major increases or spikes. You may argue the kind of 29 and 30 year olds, which is the broken blue line with the X's, that had a bit of a spike between 2015 and 2018, but that also has declined. And even since 2020, there haven't been any major spikes. So use patterns have been fairly stable across age groups, really since early 2000s. What has changed, as you can see here, is overdose deaths. So a lot of the time, like the risk or the scare factor for people when treating substance use is often related to the fatality. And what we can see here is that overdose deaths also are actually relatively stable with a few exceptions. And this is mostly relative to the opioid epidemic, and especially as we're talking about wave 3, which was the synthetics, which includes fentanyl, of course. And that really began around 2013. As the introduction of synthetic opioids into the drug supply climbed, that's where we're really seeing at towards the end of 2016, 2017 and on, that's where we've seen the spike in overdose deaths. And that is really for all of these categories. So the synthetic opioids, obviously, as well as the stimulants, cocaine. We'll talk about all of that later, but again, this is all very much related to the synthetic opioids. Other than that, overdose deaths have also been relatively stable. So looking at substance use, I really want people to think of substance use as occurring on a continuum. I think it's really important that we recognize not everyone who uses is an addict. And in fact, many people use at levels that are not even considered problematic or could be classified as a substance use disorder. This is something that's really important to keep in mind because I think there are really big implications here for treatment, and we'll talk about that a little bit later. But as you can see, substance use occurring on a continuum all the way from no use all the way down to substance use disorder, which we'll talk about. But there is a whole lot that exists in between there. So substance use disorders, we're going to really be looking at it, breaking it down according to the DSM. It's very similar also to the ICD codes, which are used for billing purposes, but this is really, to me, DSM is just a little bit cleaner to take a look at for this. This is to diagnose a substance use disorder. I want to note, though, that it is also further broken down by drug class in the DSM. So you can, this is going to be in order to have a substance use disorder diagnosis. However, you can also break it down by a marijuana use diagnosis, an alcohol use disorder diagnosis. So it is broken down further. But again, for our purposes for today, we're just going to look at kind of big picture. And the DSM identifies it as a pattern of substance use leading to clinically significant impairment or distress as manifested by at least two of the following occurring within a 12-month period. So the things that we're looking for is that the substance is taken in larger amounts or over a longer period of time than was intended. There is a persistent desire, unsuccessful efforts to cut down or control your use. A good deal of time is spent trying to obtain the substance, use, recover from its effects, etc. There we go. They do spend some time looking at cravings or urges to use, recurrent substance use resulting in a failure to fulfill major role obligations, whether it be work, school, home, etc. Continued substance use despite having persistent or recurrent social or interpersonal problems caused by or exacerbated by the effects of the substance. It impact on important social, occupational, or recreational activities. It also looks at recurrent substance use in which it is potentially physically hazardous. And substance use, the substance use continues despite knowledge of having persistent or recurring physical or psychological problems that the use has created. And then, of course, we have tolerance and withdrawal. So we'll talk a little bit more about these as well next week. But tolerance is looking at need for more of the substance to achieve intoxication or the desired effect, or a diminished effect when you use the same amount. And then withdrawal, looking at characteristics of withdrawal syndrome for the substance, or the substances used to avoid the withdrawal symptoms. We also kind of qualify it as well. So it's not just you have a substance use disorder or you don't have a substance use disorder. We've decided that it can be mild, moderate, or severe. So if you have 2 to 3 of those symptoms that we just looked at, that would be considered a mild substance use disorder. Anywhere from 4 to 5 symptoms is a moderate substance use disorder, and 6 or more of those symptoms is considered a severe substance use disorder. So those qualifiers. Additionally, we have the qualifiers of in early remission. So you have no symptoms except for cravings from anywhere from 3 to 12 months. And then we consider sustained remission, no symptoms with the exception of cravings for more than a 12-month period of time. So as you can see, it's not just use or absence of use that we're looking at. There are a lot of factors that really go into it to determine whether or not one has a substance use disorder. So how substances work. I think this is also really important. I spent a lot of time in college and grad school looking at psychopharmacology. It's one of my kind of like geek areas that I really enjoy. This is a very simplified version of neurotransmission. But essentially what we want to understand how substances are working on our brain. So virtually all psychoactive substances, so all of the things that we're going to be talking about later on, work by interfering with or altering how neurons communicate with one another. So we may remember this from some of our classes. Neurons communicate by releasing neurotransmitters across the synapse. And once the neurotransmitter crosses the synapse, it binds to the receptor on the receiving side, and that's how the messages are transmitted onward. So some of the drugs that we're going to be talking about increase activity, which are the agonists, while others reduce activity, which are the antagonists. So again, just kind of wanted to give an idea of how that's happening, as we are going to be talking about the neurotransmitters, what's working on the brain where. I also want to share that route of administration also matters here, as this can impact the timing of this process. So generally speaking, when we are, the IV use and inhalation are going to be the fastest, as the drug goes directly into the bloodstream, and you're going to be able to start feeling the effects in as little as 10 seconds. Oral would be the slowest route of administration, generally 20 to 30 minutes, as the substances has to pass through the digestive tract first. And I just wanted to throw this up here to give you an idea. Again, this is more just as a reference point for some of the neurotransmitters that we're going to be talking about and the areas that they're going to be impacting, some of the behavioral health diagnoses that may be associated with too much, not enough of these particular neurotransmitters. But I have this on some of the slides as we move forward as well. Excuse me. All right. Before we get into the particular classes, I did also just want to go through drug scheduling. So this came from the Controlled Substances Act of 1970 and is really just sort of the government's way of helping us identify and regulate what drugs are safer, if you want to say it that way. And they are classified as in Schedule 1 through 5. So drugs in Schedule 1 are I don't want to necessarily say more dangerous, but they are substances that have a much higher potential for abuse or dependence and really no medically accepted use. And they're not considered to be safe to use under medical supervision. And then as you kind of go down to Schedule 2, Schedule 3, 4, and 5, they become a little bit less potential for abuse or dependency and have more medically accepted uses within the US. So this is just another way that we kind of look at classifying. And again, I'll talk a little bit about this as we're going on with some of our different substance classes. So let us go ahead and start with the CNS depressants. So our central nervous system depressants work by increasing production of the neurotransmitter GABA, which in turn slows down our brain activity. Some of the things that are included, you can see here, barbiturates, benzodiazepines. I have a few of them listed, sleep medications, alcohol, GHB, Rufinol. A number of these substances are considered to be Schedule 4. But some are also included up in Schedule 1 as well. Excuse me. Just a little fun fact in case anyone was interested, while Rufinol is considered a Schedule 4 drug, it is illegal in the US and carries penalties of Schedule 1 drugs. So I just that was something that I did not know, found interesting, and wanted to pass on to all of you. So these are all of the things, or a number of the things that are included in the CNS depressant category. Some of the street names that you may hear people saying when they're referring to some of these substances. Again, this is really just a very, very brief rundown of them. What do they look like? They multicolored pills, tablets, powders, syrups, liquids. I actually have a slide right after this that'll show a few of the different things. But why do people use them? They relieve anxiety. They produce some mild euphoria. They may cause a little bit of confusion or memory impairment. Effects on the body, as you can see, it's slowing everything down. So our breathing is slowed, our blood pressure is lowered. We have a marked loss of motor coordination, blurred vision, things like that. Some of the overdose effects, again, this is going to be when kind of taken in the more extreme, can be extreme drowsiness, extreme confusion, impaired coordination. This is one of the categories that can really impact the body pretty significantly. Decreased body temperature, seizures, coma, death could be some of the overdose effects. When we're talking on kind of the opposite end of what does it feel like to withdraw from these substances, some of it is going to be actually pretty similar to the overdose effects. We can have, nausea, vomiting, weakness, muscle stiffness, or pain, where people really become concerned with this particular class. And again, we'll talk about this a little bit more next week, but particularly for things like benzodiazepines and alcohol are when people develop DTs or delirium tremens. The onset for that is usually about 3 days or so into the withdrawal and can last for 2 to 3 days. The concern there is for the confusion, hallucination, hallucination, and the increased body temperature, which can lead to seizures and death. Again, that is definitely more on the extreme end with very substantial use and a bit more prolonged use. And just to give you an idea of some of what we are looking at when it comes to these. All right, next up, the opposite end of the spectrum, the CNS stimulants. So this is going to be working on a few different neurotransmitters, the glutamate, dopamine, norepinephrine. It's going to increase alertness and brain activity. So what we have in here are amphetamines, methylphenidates, ephedrine, cocaine, methamphetamine, cat, things like that. Again, a lot of medical purposes in here, but many of these are classified as a Schedule 1 and 2 just because of the high abuse potential. So, the controlled substances, a lot of our ADHD medications and things like that are falling in this particular category. And as you can see, just a few of the street names that we have right here. Go. What does it look like? You'll see that in just a minute. Pills, powder rocks, injectable liquid, flowering shrubs for the cat. Cat is not something that I have encountered too frequently, but it's in there. Wanted to be able to throw it out. So people use this because of the stimulating or upper effect that it has. Exhilaration, enhanced self-esteem, the improved mental performance and activity, euphoria. On the opposite end of that, it can also induce agitation, panic, and paranoia. So some of the effects would be the extended wakefulness, loss of appetite. This is definitely one of those categories we're going to be talking about, kind of the crossover between substance use and eating disorder. This is definitely one area where you're going to see some of that because of its effect on appetite and things like that, and ability to have more energy, do more things. That this is something that you do sometimes see in individuals with eating disorders. But again, headaches, chest pain, palpitation, excessive sweating, all of that. Some of the overdose effects could be high fever, hallucinations, convulsions, cardiac arrest, stroke, death. The withdrawal effects from this particular category, you're going to see kind of some of the opposite here. You're going to see dehydration, chills, fatigue. You'll see a lot of sleep disturbances, slowed heart rate, paranoia, things like that. This is what we are taking a look at. Again, you see a number of different things that fall in line here. So we've got Adderall, a few iterations of methamphetamine up in the right-hand corner, powder cocaine, crack cocaine over on the left. All right, the hallucinogens category. So this particular category is altering our serotonin receptors in the brain and changes in the chemical balance at the NMDA receptor. So we're impacting mood, perception, cognition, and activities related to self-awareness, which is what hallucinogens do. The things that are included here would be some of our psychedelic drugs, LSD, mescaline, psilocybin, the dissociatives, ketamine, PCP, and then kind of a non-classified group, if you will. So MDMA, ibogaine, salvia, things like that. You can see some of the street names down here, and then noting that most of the drugs in this particular class are Schedule 1, with the exception of ketamine, and that is a Schedule 3. We'll talk a little bit more about that in just a minute, and some of the developments with that. What do they look like? I'll show you in a minute. But we often think about this as being kind of like brightly colored pills, blotter paper, sort of those, club and, all of that kind of stuff. The effects and why people will use it would be perceptual distortion, distortion of time and place. There is like a euphoria that can be associated with this. Um, it obviously will induce hallucinations, hence the name, memory issues, confusion, things like that. Some of the effects on the body, elevated heart rate, increased blood pressure, you'll see kind of dilation of the pupils, nausea, vomiting, muscle tension, cramps, chills, blurred vision, dehydration. Some of the overdose effects, unconsciousness, slow breathing, a really sharp increase in body temperature. There can be liver, kidney, or cardiovascular system failure, brain swelling, and death related with, again, more significant hallucinogen use. The withdrawal from this, because of the impact on serotonin levels, the effects of anxiety and depression when withdrawing from hallucinogens can be pretty significant, along with confusion. Weeks or months after taking some hallucinogens, some people may develop hallucinogen persisting perception disorder. So this is going to be flashbacks or recurrences of aspects of the drug experience. And again, that is in the absence of the use of the drug. And it can happen for a considerable amount of time after one has used it. Some other risks associated with hallucinogens: long-term or sometimes permanent problems with memory or learning, and some more impactful damage to the serotonin system. I do want to speak for just a minute on ketamine and psilocybin, because I know that those are two pretty hot topic issues in the world of psychiatry really right now. So ketamine and esketamine are being used for the treatment of depression and depression with suicidal ideation. So low doses of ketamine are given IV, though this is not FDA approved right now. And esketamine, which is kind of like ketamine's close cousin, is given intranasally. That has been FDA approved, but is generally a little bit more expensive. This is different than taking ketamine for the hallucinogen purpose. It is, it is more monitored, obviously, and it is at much different doses than what people are taking when they're using it for an abuse purpose. I also did just want to touch really quickly on microdosing, as I know that this is something that has come up at a couple of our sites in the outpatient world. This is commonly done with LSD and psilocybin, and essentially microdosing is using 5 to 10% of the usual psychoactive dose in order to gain mind-altering benefits without experiencing impairment to normal functioning. And I'll kind of put that in quotes. The benefits are said to include improved cognitive functioning, increased energy, regulating emotions, improve anxiety and depression. None of this has been FDA approved. So I will just leave that there. And to give you a quick visual of some of what we've just been talking about here. All right. Inhalants. So these are really something that we don't see it a ton, but I did want to include it. They operate in a similar way to the CNS depressant category, with GABA and dopamine sort of mediating the neurobehavioral effects here. Some of the things that are included, it really is a lot of household products, just things that you can find pretty commonly anywhere you are. So paint thinner, gasoline, lighter fluid, nail polish and nail polish remover, glue, hairspray, whipped cream dispensers, chloroform, room deodorizer, all of that stuff. You can see some of the street names right here. As I said, they're common household items. And one of the reasons that I wanted to bring this one up is because of the ease of accessibility, the age of onset for this particular class is often much lower. So generally speaking, about the statistics say that about 1 in 5 kids have used inhalants by the 8th grade. It's everywhere, and it does, produce I don't know why one would want these particular effects. However, there are some cognitive impairments that come with it, ranging from mild to very severe dementia. There is slight stimulation at like immediate onset of the use, but then there's also loss of consciousness, irritability, depression. Some of the effects on the body, as you can see, slurred speech, lack of motor coordination, dizziness, drowsiness, headache, weight loss, the red eyes, watery eyes, runny nose, things like that. Some of the overdose effects, if you will, loss of consciousness, damage to the nervous system and other organs, and irregular and rapid heartbeat, death by asphyxiation or suffocation, as that's essentially what you're doing. You're cutting off the oxygen supply to your brain. The withdrawal from this, some of the symptoms or experiences could be anxiety, depression, nausea, vomiting, sweating, difficulty breathing, hand tremors, restlessness, things like that. All right, narcotics. This is a big one. Also known as opioids. They attach to the mu receptor and release dopamine, which blocks pain signals and also stimulates the reward and pleasure centers of the brain, which is exactly why people use them. Here are all of the things that are included, ranging from opium, we've got heroin, oxycodone, all the way down to fentanyl. I included this table again, just to kind of show you like the relative potency. So generally speaking, morphine is what they use as like the baseline. And from there, everything is measured as how potent is this in relation to morphine. So you can see that on this table, oxycodone is 1.5 times more potent than codeine is. Just for context, heroin is about 1 to 2 times more potent than morphine. And then we have things that go all the way up to fentanyl, the transdermal patch, which is 100 times more potent. The substances in this category vary from Schedule 1 all the way through Schedule 5. So how can an opioid be a Schedule 5 drug? Well, cough medicines that have less than 200 milligrams of codeine per 100 milliliters are considered to have less abuse potential and obvious medical benefits. The street names we can see right here, and we will talk a little bit more in just a moment. I do have some pictures of what some of these things look like. But as you can see, tablets, capsules, skin patches, chunks in varying colors. I'll show that in just a moment. Liquid syrups. Why do people use them? They reduce tension and anxiety. It does produce like kind of that initial and momentary euphoria, but there's also impaired concentration and confusion that come along with that. The effects on the body, again, much like the depressants, this is going to really kind of slow everything down. So we have slowed physical activity, constriction of the pupils, everything is sort of flushing. There could be constipation, nausea, vomiting, slowed breathing, sedation, things like that. The overdose effects, I know that this is something that many of us are familiar with, as this is what is often kind of splashed across the headlines, but there is extreme drowsiness, respiratory depression, blue lips and fingernails, lowered blood pressure and heart rate that could lead to coma and death. So, you kind of talk about like the nodding and just the sedation, that's what this is looking at. Withdrawal from opioids, I do want to state it is uncomfortable, but it is not fatal. It will feel really, really terrible, but a person is not going to die from opiate withdrawal in and of itself. Opioid withdrawal can begin anywhere, within 8 hours of the last use and can last anywhere from a few days to a few weeks. Some of the symptoms: anxiety, depression, agitation, sweaty, runny nose, aches and pains, stomach cramps, nausea, vomiting, feels like the flu. has been the described experience. So if we just want to take a look, again, it comes in a lot of different forms. I will kind of point out in the center are a few of the different, and right here on the left are a few of the different presentations of heroin. Again, just fun fact for anybody who's interested, some of the differences in presentation of heroin are due to their source. So white powder heroin, which you can see kind of center right, comes from Southeast Asia. The off-white or light brown powder comes from Colombia, generally speaking, and then the darker brown, coarser powder from Southwest Asia. And then the black tar, those liquid packets up in the center top would be the Mexican, where the product that's coming from Mexico. So it really is very dependent on where the heroin is coming from as to what it looks like. Certainly, I want to make sure that I cover fentanyl in a little bit more detail rather than just lumping it in with the narcotics alone, because we've definitely seen this explode and exacerbate the opioid crisis over the last 10 years. What is fentanyl? It is a potent synthetic opioid that has been approved by the FDA for use as an analgesic and anesthetic. What is it exactly that makes fentanyl so dangerous? So part of it is that it is 100 times more potent than morphine and 50 times more potent than heroin. In my opinion, an even bigger part of that is because it is so much cheaper to produce than heroin. Because it is cheaper, it is put in everything. So 7 out of 10 pills seized by the DEA contain fentanyl. So again, unless you are getting your prescription, unless an individual is getting their opioid prescription directly from their doctor and picking it up from the pharmacy, if it is coming anywhere off of the streets, you have a 70% chance, if not a little bit higher, that it is going to contain fentanyl. Estimates are that anywhere from 60 to 80% of the illicit drug supply contains fentanyl, and it is generally most commonly found in opioids, so powdered heroin, counterfeit pills, things like that. But a lot more recently, we've also seen pretty significant increases in contamination of cocaine and methamphetamine. So if you remember back to one of those first slides where we kind of looked at the overdose death rates spiking, it wasn't just the fentanyl or the synthetics that were included in that. More recently, we've also seen the increase in the amphetamines or the stimulants and cocaine, which is also a stimulant, but they had it broken down differently. And again, a really dangerous component about this is many people will take fentanyl intentionally. However, many people who are consuming it don't realize that they are taking it. So especially those who are, who may think that they are taking just heroin. I was at a training recently that basically said there is no just heroin anymore. People who think that they are taking cocaine or think that they are using meth don't realize that what they're consuming contains fentanyl, which is part of the danger. All right, cannabis, another big one. It impacts the release and reuptake, of the neurotransmitters dopamine, glutamate, serotonin, and GABA, which impact cognition, motivation, and mood. So what is included here? Marijuana and its 480 known compounds, as well as marijuana concentrate. I'll show some pictures in just a minute, and you can see the street names here. Cannabis, again, just for anybody who's not familiar, it is currently legal for medical use in 38 states and legal for recreational use in 24 states, including right here in New Jersey. However, federally, it is a Schedule I drug. What does it look like? We'll take a look in just a moment. What are the effects? Memory and learning are impacted, distorted perception, there is confusion, there could be paranoia, heightened imagination, thinking and problem solving are impacted. Some of the effects on the body, and again, this is part of the reason that people use it: increased sociability, disinhibition, relaxation. So really, kind of trying to, help more of like almost like a social lubricant sort of thing. Dizziness, nausea, reduced concentration. There can be some agitation, restlessness, increased appetite, increased heart rate. Some of the overdose effects, if you will, would be nausea, tachycardia, tremors, delusions, things like that. Withdrawal, it's not a fatal withdrawal, but it certainly can occur. It actually does occur in about half of regular users upon discontinuation or significant reduction. And most of those symptoms of cannabis withdrawal will look like anger, irritability, anxiety, depression, restlessness, troubles with appetite. So again, they're on kind of the milder level of what one would consider withdrawal, but it does occur, and it is important to recognize that it occurs even with just marijuana, because that is, that can be a real deterrent for people. People don't want to experience that unpleasantness, and so return to use can be quite quick. And just a little look at a few of the products. Steroids. I toyed with whether or not to include this, because again, it's not something that is super duper common. However, again, because of the potential for use, and the risk for individuals with eating disorders, because people use it to achieve a certain physical appearance, thought I'd go ahead and throw it in. So we're talking about anabolic steroids. It activates components of DNA and muscle cells that increases production of the proteins that build muscle tissue and fibers, which increases muscle growth and body mass in a short period of time. You can see all of the things that are included. They are Schedule 3. But I think it's important to note that because of the quick impact on physical appearance, this can lead to pretty rapid addiction, if you will. The use is often associated with men to improve like physique or athletic performance. But again, because it can also be used to help people achieve a certain amount of physical appearance, it can be used, and it is used by women as well. The way that people tend to use steroids can be broken down in a couple of different ways. So there's stacking, which is like taking multiple different types of steroids at a time. So, the really, really rapid effect, cycling, so taking for a certain period of time, like 6 to 12 weeks, and then abstaining to sort of let the body recover, or pyramiding, which is gradually increasing the dose during an on cycle and then tapering during an off cycle. So those are ways that individuals generally will use steroids. What does it look like? I think I showed a picture just a second ago. Generally tablets, capsules, liquid, things like that. Effects on the mind can be mood swings and aggression. Effects on the body, aside from the desired physical effects, we can see things like acne, fluid retention, deepening of the voice, increased facial and body hair, menstrual irregularities for females, baldness, male breast tissue enlargement, things like that. Overdose effects, when used again to the extreme, could be coma, heart attack, and stroke. Overdoses are really extremely rare for this class. However, there are a number of other risks that could be associated with injections, such as infection, contaminated equipment if you're sharing needles, things like that. In terms of withdrawal from steroids, again, it does exist. Trouble concentrating, muscle aches, joint pain, nausea, vomiting, weight loss, decreased sex drive, and then a very, very significant depression can also be associated with withdrawal from steroids. Because I look like I'm doing okay on time, I am going to go through all of the drugs of concern. So we're moving out of kind of the different drug classes and into some that are not necessarily scheduled or part of any particular class, but are out there and that I hear a lot about either in my work with some of the teams or in, community meetings and things like that. The first one, this is a special shout out for anyone who works with child and adolescent that's out there. K2 spice. So this is a synthetic cannabinoid which impacts the brain by binding to the same receptors as THC. It's dried plant material that is sprayed with chemicals, and it's often sold in gas stations or convenience stores. It's an herbal incense potpourri. It is labeled not for human consumption. That does not stop humans from consuming it. The effects on the mind, acute psychotic episodes, intense hallucinations, agitation, disorganized thoughts, paranoid delusions. This is definitely something that I know our BHED will see some of coming in. The body, you'll see elevated heart rate and blood pressure, loss of consciousness, tremors, seizures, vomiting. The overdose effects include seizures, stroke, coma, and then death due to heart attack or organ failure as a result of use with this. So some of the components of K2 fall under the Controlled Substances Act as Schedule 1. But one of the really tricky things about things like K2 spice and some of the others that we're going to be talking about is that the ingredients and the formulation changes so frequently that the product itself is difficult to classify. So because of the constantly changing formulation, they can't narrow it down and say, okay, K2 spice, you can't, this is banned because it's never the same. Though use of this can be subject to prosecution if certain criteria are met. And you'll find that the same is true with, I believe, yes, our next drug of concern. This is a relatively newer one and not something that we've seen a lot of, but I think it's pretty interesting. This is tianeptine. So it impacts serotonin and glutamate, impacting mood and resulting in euphoria at higher doses. So atypical tricyclic antidepressant with opioid receptor activity. It's sold at gas stations as a dietary supplement and comes under the name Neptune's Fix, Tiana, or Zaza. So some of the effects on the mind would be headache, insomnia, nightmares, and hallucinations. The increase in the effects on the body, increased blood pressure, irregular heartbeat, difficulty breathing, loss of consciousness, and then some of the effects, seizures, liver and kidney damage, and possible death. So this is not FDA approved, and to get around they get around the guidelines because it is sold as an adulterated dietary supplement, which means that other substances may be present. The FDA did recall this back in January of this year, but it is still available. And just as of last report, I believe, the last reported overdose in New Jersey was in August of this year, and then the last reported death in New Jersey was in March. But it should say that most deaths from this substance, there were other substances involved. So a newer one, something to just kind of be aware of. Kratom, again, this is one that I know we do see in spurts in the outpatient world, and I imagine is other places as well. So this interacts with opioid receptors in the brain to produce stimulant-like effects at lower doses, and then more opioid-like effects when it's used at higher doses. What is it? It's leaves from a tropical tree that are actually a part of the coffee family, native to Asia. The leaves are crushed and then smoked, brewed, or placed into capsules or tabs. The effects on the mind would be increased alertness. There can be psychotic symptoms, including hallucinations and delusions. Effects on the body, nausea, increased energy, sweating, dry mouth, loss of appetite, things like that. Overdose effects, seizures, liver damage, and death, but that is rare. Currently for kratom, it's not FDA approved for any type of medical use. I know that there are a lot of arguments that this is an herbal alternative to managing opioid withdrawal, but at this time, the evidence simply does not support that. The withdrawal from this can look like gastrointestinal upset, restlessness, irritability, low energy, things like that. Another question that I often get asked about is, can we drug test for this? The answer is it can be tested for in urine, but only really on extended panels. And that's, it's not very common because it's not illegal in most states. So a lot of panels do not include this and it would be an add-on. The last drug of concern, just keeping an eye on the time, I'm going to go quick. This is another pretty big one. Xylazine, CNS suppressant that slows the release of dopamine and norepinephrine, resulting in sedation. So this is a veterinary tranquilizer that has much more recently been added to the illicit drug supply, specifically in opioids, to exacerbate the effects. Makes for a better high. The increase on the mind, again, that of a depressant, it's going to slow everything down. You can see some of the overdose effects there. This has really increasingly been found in the illicit drug supply since 2020, and the Northeast has really been having the highest rate, and that's likely due to the high prevalence of fentanyl in our drug supply, because again, this is paired with it due to increasing the high. Important to note here, while it does have, some of the same effects on the body as opioids, Narcan does not have an impact on this drug. And it's happen is, an individual who is on xylazine or has used xylazine, will present as though they are, having an opioid overdose, and it can sometimes actually lead to precipitated withdrawal because the Narcan dosing is pretty excessive. It doesn't have, they're not kind of coming out of it with one dose, so they'll be dosed again, which can lead to some of those precipitated withdrawal symptoms. So finally, well, like I said, we're going to discuss more of the various treatment modalities next week. But for today, I really just wanted to end by focusing a little bit more on the how of treatment. I think it's important to remember this population, generally speaking, has not often had a positive experience in healthcare settings. So we need to really ensure that the approach that we are taking is both supportive, but also welcoming and affirming of their lived experience. It is a very complicated patient presentation, so it requires a really comprehensive approach. What we are looking to do ultimately is promote dignity and respect for all individuals, really meeting people where they are at in their journey, and then providing supportive and non-coercive services to all individuals. So I'll just kind of end on how we can do that just in our daily practice. So first and foremost, recognizing that substance use occurs on a continuum, as we said in the beginning, and not everyone who uses has experienced negative consequences. I will follow that up quickly by saying that negative consequences are relative. So while we may be seeing people who have just come out of the hospital or who are in the hospital or in the ED, and we would consider that a negative consequence as a result of their use, that may not be a negative consequence for that individual. It's important to remember that patients may not be ready to discontinue their use right now. That's part of meeting them where they're at. I know that historically the field has been very, abstinence dominant. One of the things that we've definitely seen more recently is a shift away from that towards a more inclusive harm reduction approach that really just embraces encouraging safety and looking for any positive change. What can we do to improve this individual's quality of life and make sure that they are at less risk for adverse consequences as a result of whatever use may continue? And then really looking to focus on partnership and connection. Again, we can't necessarily begin by launching directly into, best practice, evidence-based approaches without first having a connection with these individuals. Because, I think especially for this population, that is the key to engagement, is connection. We need to be genuine, we need to be kind, we really need to be patient. So more on, some of those particular approaches to do this next week. But for now, just the how of doing it. I have a pretty extensive reference list that you'll be able to take a look at. But is it all right if I stop sharing and look at live people again, Becca?
That sounds great. Thank you so much, Sarah. That was wonderful and so informative.
It was a lot. I know. I'm sorry.
Yeah. No, I loved it. It was great. And it looks like we have time for 1 or 2 questions. I don't see anything in the chat. Does anyone want to unmute or put it in the chat for us? I'll give everyone a second to be brave.
No, not a question. Sorry. Not a question, just a comment. Thank you so much. That was very, very, very informative. I actually learned a lot from this session, and I'm hoping that next week we can dive more into treatment modalities. But this really was good. I hope we could get the PowerPoints because I'd have to see it again.
I know there was a lot, but I think, like I said, a big part of this is when you know what you're dealing with, it makes it a lot easier to treat, because that just sort of fear of the unknown and feeling, not confident in what it is that you're seeing or what it is that what it is that a patient is experiencing, can definitely be a really big barrier. So thank you, Tashika.
Thank you so much for this talk. It's very informative and it's going well with my class materials as well. So it's really adequate timing for me.
Great.
I am really curious to learn a little bit more. You mentioned that Narcan, I forget for which drug, may lead to increased withdrawal symptoms. Is there best practice for, because I know there's a lot of campaigns going on for getting access to Narcan and like providers carrying it. Is that a concern, or are those?
So the concern is really on using Narcan for a patient who is not only using opioids. So a lot of the issue is that, and it's really tough because we want our law enforcement, our first responder, everyone to be prepared and to save lives. But sometimes what happens is they will rush in and immediately Narcan, and Narcan multiple times when it's not responding to the Narcan because it's not an opioid. So, there was actually a really, really fantastic grand rounds that was done a couple of months ago. Dr. Fernando Montero, I believe. I'd really encourage you to check that one out because he really got into a lot of this. But it's, this is where really kind of like, the first responders and people in the community knowing what's going on with substance use patterns in the community is really important, and not being super overzealous, because individuals who are using xylazine are not really wanting first responders anywhere near them because they're just being Narcaned and then incredibly uncomfortable as a result. So I would definitely check out that particular grand rounds because it was awesome, and his work in Philadelphia is great.
Thank you so much. I appreciate it.
Absolutely.
Awesome. Well, that is all the time we have for today. So we can look forward to hopefully many more questions and answers next week. Thanks for joining.
Thanks, everyone.